for graduate education at Indiana University School of Dentistry and an attending at Raleigh Children's Hospital. It occurs to me, Dr. Yepis, that when I was a student, I probably would have spent a lot of time in your office being disciplined for antics. So Dr. Yepis has a master's degree in public health, and notably, in addition to everything else that he has achieved, Juan is also a fellow in dental surgery for the Royal College of Surgeons at Edinburgh, and a member of the editorial board of OO, Oral Surgery, Oral Medicine, Oral Path. Without a question, Dr. Yepis is among my favorite speakers that I've ever encountered, and I include all of them. Without further ado, Dr. Juan Fernando Yepis.
Well, Dr. Samson and Allison, I don't have enough words to thank you for this invitation. I love to share, knowledge, and I love to create more friends and to have a bigger network of friends and colleagues around the country. And I hope that, people, I know it's difficult sometimes to take away this hour in the middle of the day, depending on the time zone that you are. For me, it's 1 p.m., but I know for some of the attendees, it may be a little bit early or a little bit late. But anyway, I wish I will be in front of all my attendees to shake hands and say thank you so much. I'm very humble, and I never in my life really expected that I will be giving a lecture and my colleagues will be listening to me. I mean, that's something that I need to be very thankful every single time that I'm ready to start a lecture. So thank you, Dr. Samson. I can call you Gerry, and I call you my friend. And in these days, in the way that I get older and I get closer to the cemetery, I start to realize that the word friend is only reserved for the true friends. When you are younger, you call friend a lot of people that you don't even know. Don't know. You can have 1,000 friends in Instagram, 2,000 friends in Facebook, but everybody who is younger than me or younger than Dr. Samson, eventually you will realize that you can count in one hand the number of friends that you have. And I guess when you are really close to exit this world, you realize that friends probably will be just in a few fingers. And Gerry, I count you as one of my friends. So thank you so much. Well, without any more introductions, I want to make this lecture really a very relaxed lecture. I really want to kind of have, I know we are going to have questions at the end, we will have some time to do that, but I just want to kind of, look at the title, OSA, Obstructive Sleep Apnea in Children and Adolescents, and really provide you with a 10,000 feet overview in a very relaxed way. I promise you, I'm not going to move too deeper in the knowledge. But we are going to learn what we're supposed to know for OSA and maybe open the door for future webinars if we want to go deeper in terms of treatment and especially treatment options that we can offer to patients with OSA. So I will say in some way that this lecture is like an introduction, like a general overview of OSA. I know this is one of the hot topics these days in dentistry. So I will assume that pretty much all the attendees, you have a general idea about OSA. This is not something new. And but I will just grab your hands and we are going to walk together and increase our knowledge about OSA. As Dr. Samson mentioned, I work at IU. That's the house of McDonald and Avery, Dentistry for the Child and Adolescents. And I very proud believe that this is one of the best textbooks of pediatric dentistry in our country. It's not the only one, but I think it's one of the best. So that textbook is from us, was born here at IU, initially by Dr. McDonald, and then later on, Dr. Avery. And then later on, we are a team of 5 who are behind the textbook. We have a wonderful chapter in OSA, and we are active working in the new edition, which is coming by 2027. That will be the 12th edition, but we usually start to work about a year ahead. I don't have any conflict of interest. I don't have any financial conflict or any conflict with any commercial company that is going to restrict my independent judgment about the content of this lecture. I have some disclaimers. If you see any picture in this lecture, I download it from websites that I can do that. I always pay a lot of attention not to go and copy and paste, copy and paste, copy and paste, because as you know, these days it's easy to do that, but sometimes we don't know if we can use that pictures. So these are my goals. I think so the most important, and Allison is listening to this because she just asked me something before we start the webinar, is to understand how critical it is to recognize OSA. And that's my job as a dentist, is to recognize or at least smell, kind of look at me, smell that that patient maybe is having OSA. And then that smell, quote, quote, is the first step. Now, it may be at the end, the smell was wrong and the patient was not diagnosed with OSA, or maybe the smell was right. So my job is to identify patients and recognize that it's important to recognize patients early on. We are going to learn the most common signs and symptoms. If we want to recognize, at least we want to kind of understand the most common. I know I can tell you the most common is snoring. And that's, everybody will know that. But we are going to expand that a little bit more and to try to assess other potential symptoms and signs besides snoring. I understand snoring is a critical, absolutely critical one, but we are going a little bit beyond that. I probably will skip, and again, this lecture is recorded, but if anybody wants to have my PowerPoint, I will be more than happy to share my PowerPoint, but I think so intentionally, I'm going to skip the section of common imaging techniques. This is always kind of a bonus when I have more time than an hour. My background as a radiologist, I also always want to share imaging and how they can help me into the diagnosis of OSA, but I think so because the time that we have for this lecture, I probably will just say that, there is a lot of different things that you can do with panoramic films, lateral scalp projection, CBCT, MRI, CT, and a couple of more techniques. And finally, just general, what kind of interventions we can provide to patients with OSA. So this is the menu. When we go to a restaurant, this is what I'm going to offer this afternoon. And I will make sure that I go step by step. And again, probably imaging is the only one that I'm kind of move apart. Everything else I will share during this webinar. So just to kind of assess your knowledge, kind of a pre-seminar questions, I have about 3 or 4 questions that I am not going to give you the answer, but I hope that, through the webinar, you can, by yourself, you can figure it out the correct answer. So the first question is, which of the following etiologies are associated with OSA? And I have 4 options, or the last E is all of the above. So which of the following etiologies are associated or is associated with OSA? Craniofacial abnormalities, obesity, anatomy anomalies of the pharynx, neuromuscular diseases, or all of the above? The second question is just easy, true and false. You have 50-50. So this one is you. Children with OSA, they may exhibit some hyperactive activity. So what I'm trying to guess, or what I'm trying to ask you with this question is to try to start to think about the potential consequences of OSA in terms of the behavior of the child who is not diagnosed. Question number 3, this is the type of question that my students hated because I'm asking for the except. In fact, in these days, 2025, the experts in education, they suggest not to write questions with except. But I'm an old guy, and this is, from the old days, I'm still doing that. But I know some of you will cut my head here. All of the following are treatments for OSA except, so there are 4 options: rapid palatal expanders, mandibular advancing appliances, lingual frenectomy, or distraction osteogenesis. So out of these 4, there is one that, this seminar is framed by evidence-based dentistry. I'm sure all the webinars, that Dr. Samson is sponsoring, they are all framed by evidence-based dentistry, because that's obviously something that we all need to bring to our lectures and bring to our knowledge, that everything that I'm going to speak this afternoon is coming from evidence-based dentistry. Question number 4, the home sleep apnea test, or HSAT, is recommended for children ages 8 to 15-year-old. So, you are going to learn in a few minutes that the gold standard is the sleeping lab at the hospital. That's the gold standard. But there are some barriers. Sometimes it's challenging to do that. So there are other options. So one of the options is the home sleep apnea test. You can use your cell phone, you can use your watch. There are different ways that you can create like a study lab or a sleep lab in your own home. The question here is, can we do that? That's supported by evidence-based dentistry. So let's welcome our first patient next Monday. So we are ready to go and do an oral exam and, do a couple of restorative procedures. And then we have, mom is telling us, my child is having some issues at the school, difficult to concentrate. It seems like she wakes up in the morning with headache, and she's all the time drinking water. When you look at the clinical exam of this girl, you noted a constricted maxilla, so she's in crossbite. And obviously, when we look at the back of the mouth, that's my territory, that's the mouth, I see huge tonsils. And I ask mom, if your child is snoring, and it's a yes in capital letters. So that's my patient who is coming on Monday. And we are going to really center this lecture in a patient like the patient that I just shared with you. So snoring, no question about that, especially when you are sleeping, is the hallmark of increase of airway resistance. Um, it's very frequent during childhood. About 10% of preschoolers and school-age children, they snore at night. Now, the key here is not always snoring will cause gas exchange abnormalities. Let me translate that to more simple words. Not always when you snore, you are having hypoxia and hypercapnia. Not always. You can snore the whole night, and if I check your oxygen, it will be 98. The problem is if you are snoring, and together with the snoring, your concentration of oxygen is moving down, and your concentration of CO2 is moving up. That's a completely different story. So at the end of the day, about 2 to 3% of the kids who snore at night, they may have a clinical relevant disease. So they may have OSA. So let's play with the numbers. If in a busy day, you see, I don't know, 40, 45 kids, imagine that out of the 40, 10 snore, 10 kids. Out of the 10 kids who snore, maybe 2 or 3, they have OSA. So my job as a dentist is to, first of all, I think so that's the first, learning from this webinar. We need to ask the question, your kid snores, yes or not? I mean, that's kind of the basic Dora the Explorer, just asking that question, snoring or not. Then, placing that kid within the group of obstructive sleep apnea or just snoring is maybe knowing my territory as a dentist. I may see more things in the mouth, and we are going to discuss that later, but definitely snoring will be my flag to start the process of thinking it may be OSA. The ratio between snoring and OSA is about 3-1 and 5-1. I think so the next slide is important because we need to have a definition of OSA so we are all in the same page. And Gerry, and this is something interesting that I just, pretty much deal with this very in a regular basis. There are a bunch of different definitions of OSA in children. It seems like a different organization, the American Association of Orthodontics and the American Academy of Sleep Medicine and the American Academy of Pediatric. So they are different definitions. So I don't want to really enter in the discussion which definition is the most appropriate. I just decided to take one. I am the one who is leading this webinar, so I just took one from the American Thoracic Society. I think so it's probably the easy one to understand. So OSA is defined as a disease of breathing when you are sleeping, characterized by a prolonged upper airway obstruction. So that's kind of the bottom line. And intermittent complete obstruction that is going to disrupt the normal ventilation when you are sleeping. And definitely is going to alter the normal sleep patterns. So underlying or between lines, this definition is an issue with the airway that will disrupt the normal ventilation. It's going to cause hypoxemia and hypercapnia. Now, the gold standard, first time that I mentioned that, the gold standard for the diagnosis of OSA is polysomnography. That means, in a study lab, sleeping during the whole night. If we do that, if we use, as supposed to use, the gold standard for trying to establish the prevalence of OSA, using the OSA in the general pediatric population, the prevalence is something between 0 to 5.7%. in the country that we love with all our heart, here in the US, the prevalence of OSA is about 2%, 2 to 5%. Now, if you use non-gold standard techniques like the home study lab, then it's not a surprise that the prevalence will increase to 10 to 24%. But the problem is more kids probably are going to be labeled false positives. If you use, for example, the home study lab, which is not the same like the study lab using the full polysomnography, then you may well get a positive using the home study lab, but the kid is may not having OSA by the gold standard, which is the polysomnography. So we need to be careful when we use this non-standard gold standard test. Now, in just one bullet point, definitely big tonsils, big adenoids is kind of the bottom line in the majority of the patients with OSA. There are basically three types of OSA, my friends and my colleagues. The one that probably we are going to see more often in our office is type 1, which is huge adenoids. We don't see the adenoids when we open the mouth because they are really in the back. We see the tonsils, so big tonsils, big adenoids, but no obesity. I work here in a children's hospital, and I'm a member of an interdisciplinary team who deals with patients with OSA. And the majority of the patients with OSA that we have the opportunity to evaluate and to provide diagnosis and treatment, they are skinny as my finger. So there is no correlation between weight and the size of the adenoids and the tonsils. That's type 1. And type 2 is the minority of the patients, which there is a correlation between obesity and adenoid hypertrophy. But the majority of the patients, no obesity, big adenoids, and big tonsils. Then finally, there is type 3 OSA, which is a group in between, which this group is linked with craniofacial and neuromuscular disorders. That's easy to identify because these are the patients with all these different syndromes that they change the architecture of your face, and that change in the architecture of the face translate in having some breathing issues. So in the last 10 years, OSA has emerged not as a relative prevalent condition, but also a disease that comes with a bunch of different consequences. Some of the consequences, they may have long-term implications. Believe it or not, and again, getting back to my conversation with Allison just before starting this webinar, the majority of the consequences of OSA in kids who are not diagnosed involve neurobehavioral issues, lack of attention, difficult to concentrate, and a lot of things. And we will have a slide in a few minutes that will be going to review that in more detail. But not just only behavioral. And this will be a wonderful conversation with Gerry to have a coffee sitting at a table and say, well, it's not just only behavioral issues, it's also cardiovascular, endocrine, and metabolic issues. The underlying physiopathology, this is almost like a rocket science. The underlying physiopathology of OSA is the trigger of inflammatory pathways in your brain. What's the link? Why if I snore and I have hypoxia because I'm snoring, why that is going to trigger inflammatory pathways? It almost sounds like Yepes is here trying to kind of guess and make it up. I mean, believe me, when I start to become interested in OSA and I start to dig deeper in the reasons of OSA and the consequences of OSA, I start to open the door of something that is way beyond my knowledge and my ability to understand, which is what happened in your brain when you are driving with a low oxygen level. And that's what happened during the night in patients with OSA. And then basically what happened is that low oxygen that you are driving your brain is going to trigger inflammatory pathways. And the inflammatory pathways are the one responsible for the whole portfolio of consequences. This is a night table that I played this table for this particular webinar. I knew that Dr. Gerry will love it to see it because I like to kind of present the information in a way that is easy to understand. So this table is, I just want to make the differences between OSA in adults and the OSA in children. They have the same name, OSA, same name. At the end of the day, the physiopathology maybe is the same, hypoxia and hypercapnia. However, there are significant differences between kids and adults with OSA. For example, and I don't want to really read this slide, there is one, adults with OSA 90% of the time obese. Children with OSA, not really. So that's a big difference. I take one more. Awakening at the end of the apnea episode. That means that you are sleeping, you have the apnea, and then you awake. Adults, very often, they kind of awake, and then very quick, they will again get into sleeping. Kids, they don't. They go into the apnea, and then they kind of recoil and start the new cycle again, but they don't wake up. For adults, the major consequences of OSA are heart-related, cardiovascular. For children, the major consequences of OSA are behavioral changes, neurocognitive deficit. This is so interesting. I don't know why. I wish I know why, if the physiopathology at the end is the same, hypoxia and hypercapnia, why the sequela is quite different when you look at adults and when you look at children. The same issue, oxygen low, CO2 high, intermittent apnea when I'm sleeping, but the consequence is different. No clue. Epidemiology, just a few slides. In children, the most common ages that we can identify kids with OSA is in between 2 and 7. And there is a reason, because at the age of 2 is usually when the adenoids, they will get to the bigger size. And it's around the age of 6 to 7 when the tonsils will get to the bigger size. So if you have hypertrophy, if they grow more than they're supposed to grow, then we are going to identify the patients between these two different peaks. That means that between the ages of 2 and 7. It's not reported by parents. If I ask every single mom and dad, hey, your kid is snoring, the studies found that the parents, they will report that something in between 1.5 to 6.2%. Now, parent-reported apnea, that's different. That the parent is saying, oh yes, my kid almost stopped sleeping, is about 4%. So the prevalence of OSA diagnosed with additional diagnostic testing is, again, my magic number, 1 to 4%, which seems to be very consistent across all the studies. Let's go into the etiology. So I'm going to kind of use a couple of slides, and I will split this in 3 different sections. Etiology, physiopathology, and then if you're still awake and you're still trying to follow my amazing, beautiful accent, not really, but I believe that having an accent is my best friend. I wish I see accent working aloud. I mean, walking in front of me, because I will run and give a hug to accent. Because believe it or not, for educational reasons, having an accent is beautiful. Because what happened is you really need to pay attention to the slides. If you try to follow, if you are driving, following this webinar, I'm sure you already decide, okay, I'm not going to keep listening to this guy. I probably will need to kind of sit back and access the recorder. So accent is a wonderful educational friend. So I'm going to talk about these 3 things.
Your accent is from Kentucky, no?
Downtown Kentucky. Remember, I spent a lot of my life living in Lexington, Kentucky. So clearly, this is the Kentucky, what I call the Kentucky. Yes, I have been trying to learn the Indiana accent, but I believe I already failed after almost 12 years living in the magnificent state of Indiana. I cannot tell you. I probably will be lying to you, Gerry, if I say this is a Hoosier accent. So even Kentucky is not too far from here. It's our neighbor, but no, I sound like a Lexington. And let's put it in that way. So etiology, physiopathology, signs and symptoms. So this is a nice slide, again, trying to summarize. Anatomic abnormalities is probably the #1 etiology of OSA. Big tonsils, big adenoids. Could be also some issues with the architecture of your nose, like choanal atresia, or respiratory tissue thickening, or in a small number of patients, obesity. But by far, if I am going to run a quiz after this webinar, the most classical reason is big tonsils, big adenoids. Now for type 3, remember the one that I mentioned, which is the one associated with craniofacial syndromes. Well, Treacher-Collins, Crusoe, mid-face hypoplasia, micrognathia, they are some major syndromes that part of the whole issue is the architecture of your mid-face is not, doing what's supposed to do with the airflow. and that will give you a predisposition for OSA. Now, the physiopathology, this slide is clockwise. It moved clockwise, so it moved to the right. And, I don't remember from where I'm supposed to, and I said that I really make sure that the picture that I use, I can use it. This is a nice summary of the physiopathology of OSA. And again, it runs as clockwise. So if you look at noon, that's when finally sleep onset. And then we have 1 p.m., 3 p.m., 4 p.m., 6 p.m., 8 p.m., 9 p.m., 11, and noon. So we go in that direction. So as soon as we finally are sleeping, every single human, and animals as well, we decrease the pharyngeal muscle tone. And then the decrease of the pharyngeal muscle tone is going to narrow the airway. If in the top of that, you have big tonsils and big adenoids, that narrowing is going to be probably even worse. And then if we move to 4 p.m., the consequence of that, the collapse of the airway and the reduction of the airflow, the consequence is hypoxemia and hypercapnia. And then we go to 6 p.m., we try to break this. Our brain is sensing that we are running low in oxygen, high in CO2. So we are going to increase the ventilatory effort to try to reopen the airway. And then if we go to 8 p.m., adults, they wake up and then they, will reestablish the normal ventilation. Children, they will not. Then finally, I will be, I increase my pharyngeal muscle tone. And at some point, the child or the patient is going to be able to reopen the airway. And then you are going to start to breathe again. This happens 10 times during, your 7 hours of sleeping, 12 times, 20 times. This happens multiple times. You go through all these cycles. And the consequence of the cycles is your brain will be all the time under pressure, working low oxygen, and then again normal, low oxygen, again normal, low oxygen, again normal. So these two pictures, just to take a look at the normal breathing during sleep, even, if you don't have big tonsils, big adenoids, the airway will decrease the diameter because the tongue will move forward, backward. If you have a sleep apnea, the tongue will move backward, but together with the big tonsil, big adenoids, that will cause the blockage of the blocked airway. Beautiful slide. I will leave this slide for 10 seconds. So you have 10 seconds to look at this. 10 seconds to appreciate this slide. This is side to side, the symptoms and signs of OSA, side to side. And remember, one of the goals of this webinar is to identify the symptoms and signs. So this slide in some way is kind of critical slide. I mentioned snoring, but anyone knows that. But we need to add more knowledge to that brain. So symptoms, behavior, headache, difficulty staying asleep, attention problems, mouth problems, sweating, restlessness. There is a bunch of different things. And if you look at the signs, bedwetting, for example, is something that we sometimes we don't think about. Aggressive behavior, developmental delay, impaired growth, hyperactive activity, and unusual sleeping positions. So moms and dads, because I'm sure I have moms and dads in this webinar, it's not just only snoring. Yes, that's the hallmark, but there is a whole array of different things that sometimes completely unexpected. I'm sure many of you, that unusual sleeping positions, that's something that you probably first time that somebody's mentioning that connected with OSA. Okay, it's time to keep moving. Let's go with the diagnosis. In the diagnosis, it's always nice to include the word gold standard, but at the same time, gold standards comes with some problems. Not just only for OSA, for many other conditions. When you mention the words gold standard, sometimes gold standards means barriers. Either they are expensive, difficult to access, too long to wait. So unfortunately, we love, my doctoral degree is in epidemiology. And I took a lot of naps during my epidemiology classes at the University of Kentucky College of Public Health. But some of the lectures, I was awake like now, especially about gold standards, how we use gold standards when we are trying to establish the accuracy of a lab test. I remember that lecture I was away because gold standards, it's super easy to say gold standard, but when you are going to apply the gold standard, 90% of the time there is a barrier. The gold standard for the diagnosis of OSA is polysomnography, period. That is, you need to do that. You need to establish that the patient is snoring, and you need to correlate the snoring with hypoxia and hypercapnia. So now we have some helpers, and that's what I'm going to add with the diagnosis, but none of the helpers, none, is at the level of the gold standard. And unfortunately, the gold standard is not easy to access. Here in my hospital, here at Riley, if we refer a patient for a polysomnography, the waiting list is at least 5 to 6 months. And on the top of that, imagine a child sleeping in a study lab full of cables and, now sleeping in your own room with your own, Barney and your own teddy bears. And, it's a challenge. But that's what I have to say here. So the diagnosis. There is no universally accepted definition of snoring. In practical terms, snoring is the human perception and categorization of a sound that we all know how the sounds, we all know that. Primary snoring is defined as snoring without associated apneas, hypoapneas, hypoxemia, hypercapnia, or sleep fragmentation. Remember, 8 out of 10 kids who snore, they have primary snoring. They don't have any apnea, hypoapnea, hypoxemia. Snoring is frequently associated with OSA, and patients with snoring, no question, they may be at risk of developing OSA. Most children with OSA, they snore at night. So let's start with the diagnosis. Clinical exam, my territory, mouth, 100% mouth. So the first little step, and I say little because this is not the gold standard, but the first little step that I can put together now that I know that the kid is bedwetting, the kid unusual sleep position, the kid is having behavioral issues, and I know that the kid is snoring because the parent just mentioned to me that, then I look at the mouth, I look at the tonsils. There are a bunch of different classifications, and I didn't say this to Dr. Samson, but I'm not going to spend just one slide. I can spend, believe me, 20 minutes just getting over the different classifications to assess the size of the tonsils. There is the Broditsky scale, the Friedman tongue classification. There is different ways to look at the back of the mouth. We pediatric dentists, we know this because this is part of the assessment that we're supposed to do when we are working with patients with sedation. When we are going to do a sedation, part of the assessment is to looking at the airway. And if you have, for example, to kissing tonsils, so you don't see anything, you just see big tonsils together, that patient will be a difficult intubation. How about if you look at the back and you don't even see the back because the tongue is actually blocking the ability to see the back of the mouth because it's a big tongue. So that is, something that is in my territory, and for sure I can do that. Also, this is more related with growth and development. And, I have the fortune to be a good friend of an orthodontist, pediatric dentist, which is kind of a nice combination. But, as a pediatric dentist, this is not rocket science. And I can look at the face, long, narrow face, high mandibular plane angle, anterior open bite, narrow V-shaped dental arch, constricted maxilla, crowding, convex profile, narrow nose. So all these are ingredients for the soup. We want to prepare the soup, and the soup is OSA. So sleeping unusual position, bedwetting, snoring at night, I cannot see the airway, or kissing tonsils, constricted maxilla, crossbite, long, narrow face. Well, I'm getting closer to saying, Mom, you probably need to see somebody. What else? I just have 3 bullet point questionnaires. They are a bunch of different questionnaires. I have a lot of here in the PowerPoint. I'm just going to talk about one, the Pediatric Sleeping Questionnaire, PSQ. That's probably the most well-known. It is not the gold standard, but get closer to the gold standard. So the Pediatric Sleeping Questionnaire is, I have the next slide, is 22 questions. I have this in my own office. We use this here at the hospital. I have this in different language, in Spanish, in different language. And you can give this to the parents, and it's self-explanatory. The answers are yes, no, yes, no, yes, no. Oh, yes, no, I don't know. Yes, no, I don't know. So you go the first 6 questions while sleeping, that your child, and then 6. The next 10 questions, that your child, and then 10 questions. And then the final 6 questions, my child often. And then, you just go and count the number of yes. And more than, if you look at this, more than 15 yes, that's highly suggestive of OSA. And there are some studies, through the year that they try to validate this questionnaire, comparing this questionnaire with polysomnography. And I will tell you that this is probably the closer test that we have in case that we don't have a polysomnography, and we want to have more certainly that the patient is having OSA. Finally, the polysomnography, that's the gold standard. It's expensive. Sometimes for adults, it's challenging to sleep in a study lab. Imagine for children, it's double challenging. And basically what the polysomnography is going to do is going to calculate the apnea, hypoapnea index, AHI, and that's based on the number of times that you stop to breathe during the night, or you almost stop to breathe during the night. And that correlates with hypoxia. So they count how many events you have per hour, and you have 1 to 5, that's pretty much OSA. So that is what I have about the diagnosis.
Dr. Yepes, let me ask you a question.
Yes.
The PSQ form that you just mentioned, is that online for people who would want to download it?
Yes, you can download online, but if somebody maybe want the Spanish form, yo hablo español muy bien, Gerry. Puedo hablar en español sin problema. Y esta forma está en español. And so if you want this form in Spanish, I have this form in Spanish. But I always, and we in the practice, we always run this form to all the patients. So it takes 2 minutes to do it. I didn't include,
Do you do that at every recall or just on a new patient interview?
New patients interview. And if we identify somebody who is positive snoring, we may run this a couple of more times in the recall appointments, but we always, it's part of our, new patient, or patients who they, for the last 2 years, they didn't come to the office, kind of a new patient just because the time in between the last appointment, then we do that.
So is this on the Riley Hospital site, or maybe if it's easier, you could send me the PDF file and I'll send it to Allison, and people can request which one is easier.
Yeah, probably send it to you.
Okay, good. Muy bueno.
I will do that. Okay, muchas gracias. So these are the as I mentioned, gold standards, super easy to say, but gold standards is very frustrated quite often. So it's expensive, long waiting times, but no question is the only validated method for the diagnosis of OSA. But again, there are some potential issues. There are other alternatives, and remember I mentioned in one of the pre-quiz or pre-test questions before this webinar, the in-home polysomnography or the home test. And again, I can use my cell phone, and I can connect my cell phone to a Bluetooth device to look at my oxygen, and I can put a cannula here on my nose to look for CO2. So I can create like a home from scratch sleep study in my house, in the same bedroom that my kid is sleeping. You can do that, and you can record that. You can put a camera, you can record, you can have not just only a video recorder, but you can also record the snoring, and then you can correlate the snoring with the hypoxia and hypercapnia. You can do that. I'm not nobody to tell you not to do that, and I tell that to the parents to do that if they want it. But you need to be aware that the number of false positive will skyrocket 4 times. The home test will ended up saying, okay, yeah, that is something, when maybe it's nothing. So I always afraid that, a lot of false positives may, listen this, may, because this is not 100%, but may will ended up in in over-treatment. And so that is the potential issue when you use all these home tests. The next point in my webinar is imaging. And again, imaging, as I said at the beginning, if we have anybody who is interested to learn more about this, I'm going to share with Gerry, not just only the pediatric sleeping questionnaire, PSQ, but also the PowerPoint. And so, you know, they are about 20 slides about imaging. And I just want to show you kind of an appetizer. So I divide the different images, and for example, the first one that I did, they are about 5 slides, is lateral neck radiology, almost like a SEF, which I don't like to use the term SEF. That's more the orthodontists that they like to say SEF. In radiology, we prefer to use lateral scalp projection, which is the correct name, no SEF. But whatever, that's more semantic issue. But if you are an experienced radiologist or experienced orthodontist, or even a pediatric dentist, if you look in a lateral scalp projection, you can see the shadow of the airway, and you can locate the adenoids. You know where the adenoids are located. And then when you have huge adenoids, you see that for sure, you see that in the lateral scalp projection. Now, if you see the big adenoids, and then do you think you can just go and tell the parents, oh, your son is having OSA? That's, again, one more ingredient for the final soup. But I will share with Gerry again the PowerPoint. And if you want to learn more about CAM beam CT, you can use CAM beam CT. But remember the position of the patient in CAM beam CT, the patient is standing. The majority, 95% of the CAM beam CT machines available in the US, the patient is not laid down in the way that we sleep. The patient is standing, so you need to make sure that you account for that when you are going to look at the interpretation of the CAM beam CT imaging. But no question about that, with CAM beam CT, you can measure the airway, and you can identify areas of the airway who are narrowing. You can do the same with CT. So that's kind of the appetizer of imaging. Again, I am just going to kind of not going in more details here, but more than happy if you want to have the PowerPoint. Consequences, critical point of this webinar. It's not the longest point, but it's a critical. Because if no consequences, this webinar will not even probably be presented today. I will be talking about zirconium crowns and sealants and, you know, and expansion of the alveoli, but not about OSA. It must have some consequences, so it's worth it to identify potential patients. So this is a centerpiece of this presentation, the consequences. And believe me, I don't know how many times I lecture about OSA, and I still shock about the consequences, because some of the consequences are like, really? And I believe that if we all digest the consequences, then we are going to be more aware of identifying patients. So there is a significant relationship between the degree of sleep problems and the magnitude of the behavioral changes. Daytime hyperactivity and inattention are associated with having OSA. There is an agreement that the total sleep reduction may alter behavioral patterns. However, listen, this is highlighted, the disruption of the sleep process rather than the total amount of hours that you sleep is the key underlying issue with OSA. In fact, many kids with OSA, they sleep 12 hours, 15 hours, 20 hours. And you may well say, well, but my kid is sleeping all day long, so I don't think so he's suffering OSA. Well, the problem is not the quantity of hours that you spend in bed sleeping. The problem is the quality of the hours. And that applies for you, Gerry, and for me, and for Allison. You know, we adults, we know. Sometimes we can spend at bed 10 hours and we wake up like we didn't sleep. Or sometimes we can spend, 6 hours and we wake up really fully ready to do the bed and exercise and swimming or whatever you are going to do. So it's not the quantity of the hours, it's the quality of the hours. This slide is to answer the question, and I'm not getting deeper here, why not all the kids with OSA, they have the same consequences? And that's true. Not all the kids will have the same behavioral changes, the same metabolic changes. And the reason is because We have an individual susceptibility that is a genetic susceptibility to OSA. And some kids with OSA, they have more cardiovascular issues. And some kids with OSA, they may have, you know, some hyperactivity issues. So they are factors who are in some way modulating the final consequences of OSA. So don't get surprised that you cannot fit every single patient under the same consequences of this condition. Behavioral and neurocognitive dysfunction is probably the most well-characterized morbidity in patients with OSA. Associations with hyperactivity, inattention. Not all the patients will have the same, I just mentioned that. And guess what? This is Star Wars, rocket science, almost like a science fiction. What the heck with the behavioral issues? Why? Well, inflammation, hypoxia in the brain, and that's a fact. That's part of the definition of OSA. Hypoxia will trigger inflammation. And triggering inflammation is really the physiopathology behind all these behavioral and metabolic changes. Sleep modulates the immune system function, and the activation of the immune system and production of the inflammatory cytokines will affect the sleep. OSA can lead to a stimulation of a bunch of inflammatory biomarkers. This group of receptors induce the production of inflammatory cytokines as well as prostaglandins. I don't want to keep reading, but just want to leave you with one sentence. Not sleeping well and having hypoxia will lead the brain to trigger the formation of a bunch of different inflammatory cytokines that they are going to travel around your body and trigger or affect a bunch of different systems. But it's not just only that. There are other things. Hyperactivity is probably the worst, and we already mentioned that. And also, in developing children, early diagnosis and treatment of OSA may improve the long-term cognitive and social potential school performance. Sleep bruxism. Again, this is one more topic that I'm just going to leave it as it. This could be a whole different webinar because it's very interesting to try to see if bruxism in children is associated with OSA. I just will leave it as a door open. I can tell you that they are two different things. Sometimes they run together, sleep bruxism and OSA. But I can tell you almost like a fact that OSA does not trigger sleep bruxism or vice versa. It's not like a sleep bruxism will be a risk factor for OSA or the opposite, OSA a risk factor for bruxism. Quality of life and depression. The cumulative evidence indicate that both OSA and obesity, if that's the case, lead to significant decrease in quality of life in a large proportion of children with OSA. Cardiovascular effects, Gerry, unbelievable. High blood pressure. This is more adults, but children, they can also do the same. Tachycardia, high blood pressure, decrease of the cerebral blood flow, and obviously a consequence of the brain oxygenation. Okay, my friends, we got to the last couple of slides of this webinar, and we will have the time for a couple of questions. What is the treatment? This section of the webinar is just when you go to a restaurant, this is the calamari. This is the, artichoke. What is an appetizer that is very famous in all the restaurants? Calamari. This is the shrimp. This is the soup. This is the salad, the one with blue cheese and bacon. What is the name of that? Well, whatever. Why
Caesar.
this is the appetizer? The Caesar, thank you. Why this is the appetizer? Because the treatment deserves 3 hours and maybe more than that. It's controversial. There is a lot of options, but I feel pretty happy if I just give you kind of a general overview. So that's what I'm going to do. So the majority of patients with OSA are associated with adenotonsillar hypertrophy. So it's not a surprise that the majority of kids with OSA, the main treatment is adenotonsillar surgical remove of the tonsils and the adenoids. The success rate for the surgical approach is close to 85%. It's not everybody. Some patients, even after the tonsils and the adenoids are removed, they continue to have OSA, and that's probably the most difficult group. If it's not adenotonsillectomy, which is the most common and successful treatment, there are other surgical options. That's the left column. And there are others non-surgical options. In the non-surgical options, probably the CPAP is probably the second most common treatment. For adults, the CPAP is the most common treatment, together with advancing mandibular advancing appliances, which, guess what? In children, they are contraindicated. It's not a good idea unless you have a hypoplastic mandible in a particular syndrome. It's not a good idea to put the kid to sleep in protrusive. And you can do that with adults, and you can cause some issues with the occlusion, but I can imagine a child that option. So this is, oh, I'm sorry. I'm so sorry. So for children where the adenotonsillar surgery does not lead to complete resolution, the nasal continuous positive airway pressure, as I mentioned, there is a gray zone. The physicians sometimes they need to decide, about the surgery. Some ENTs are super fans of the surgery. Some ENTs, they are not super fond of that. Some ENTs, they prefer to start with the intranasal application of steroids and see if that will decrease the size of the lymphoid tissue. And then after that, they will decide, okay, the surgery. Some ENTs will go, if they really confirm big tonsils, big adenoids, maybe even without a polysomnography. If everything else is there, they probably will move forward. Oral appliances, candidates, long-term use. Well, the oral appliances are for those patients who may have consequences of OSA related with the occlusion. So patients with narrowing maxillas and patients with crossbites, they may well have a benefit of doing expansion or doing appliances who will improve the area of the oral cavity. So what is my role? My first role is to do a medical and dental history. And if the patient is not, you must do more. That's the American Academy of Pediatric Sleep Physicians Academy. They recommend if your patient is not, you need to do more. That's period. That is the end of this webinar. If you have a patient who is snoring, I think so you need to do more. At least you need to ask more. These are important items that should be considered in patients with OSA. Like many of these items we already review in this webinar: poor school performance, aggressive behavior, morning headaches, ADHD, nasal obstruction, attention problems. Then I can run the pediatric sleeping questionnaire, the one that I'm going to share to Dr. Samson. Then I do my clinical exam. And again, we already talked about what I can see maybe in a patient with OSA when I'm doing my clinical exam. Imagine kissing tonsils. So far, snoring at night, inattention at the school. Now I look at the mouth and I barely, huge tonsils, almost they shake hands with me and say, "Hi, Dr. J." And then I look at the occlusion and maybe the patient is having a narrow maxilla. So I may will intervene in doing an expander. There are two procedures that they may change the upper airway physiology, which is the rapid maxillary expansion and the mandibular advancing appliances, but obviously for patients with class 2. The rapid maxillary expansion, we all know what is that. In patients with OSA, that's not the ultimate treatment, obviously, but can help. And there are plenty of studies that they show that in patients with OSA, doing a rapid maxillary expansion will help to increase the whole area of the oral cavity. And that, no question, is a coadjuvant, is a helper in the whole treatment portfolio of patients with OSA. The mandibular advanced appliances, that's out of my territory. I don't do that. And, that will be something that if you feel that will be appropriate for the patient, obviously with the indications for the advanced appliances, then that's something that you can share with the orthodontist and then have a multidisciplinary approach. Frenectomies, I know, and I really want to get to this slide. This is my last slide. Well, I have the slide of thank you. Frenectomy, there are some, I believe, kind of discussions misunderstandings and kind of back and forward about frenectomy and the role of OSA. I can just say something, when I provide webinars, I try to provide, evidence-based dentistry. I am not against the frenectomy as part of the whole potential treatment from OSA, but definitely frenectomy is not supported by the literature as treatment to prevent future development of OSA or treatment to help with current OSA. And again, I can expand this slide and have a whole webinar about this. And with saying that, I just want to thank you for your attention. That's the email. If you want to have my PowerPoint and skip emailing Dr. Samson, you can email me, and that's my email. I was not born in 1970. I was born in 1998. But when I tried to look for Yahoo, somebody already took the 1998. So I ended up with 1970 as the only potential name for my account who was available. I think so we are over the hour. So I will, probably we don't have enough time for questions. I need to run back to the clinic. And I love this kind of activity. When Dr. Samson asked me to do this, I said, Dr. Samson, absolutely. We don't have any questions in the chat, so that's good. I love it, this fast-paced learning that push us to kind of review as much as we can in an hour. And when I have 3 hours, believe me, many of you will be taking a nap. So thank you, Dr. Samson. Thank you, Allison. I hope that this is not the last time that you are going to invite me to these fast speed webinars, because I would love to keep coming. I have a lot of different topics in my portfolio. Gerry knows that very well. He invited me always to Nashville to one of the most amazing pediatric dentistry symposium that they are in the country. We are getting together again in February, and in an amazing venue, amazing hotel, amazing food, amazing restaurant, and more important, amazing friends. So thank you, Gerry. Thank you, Allison, and have a good afternoon.
Thank you. Wonderful. Bravo. Bravo. Thank you.
Yes, thank you so much. Just a reminder, the recording will be available online, so check our YouTube page for that, and I will email it out to everyone who has attended. But yes, thank you all for attending. Thank you, Dr. Yepes, and thank you, Dr. Samson, and hope everyone has an excellent rest of their day and weekend.
Thank you.
Thank you so much, and bye-bye.
Bye.
Thank you.